Hi, everyone, and thank you for joining us for today's webinar titled Improving Care for Hospitalized Adults with Substance Use Disorder, brought to you by the American Hospital Association's Physician Leadership Forum. To present today's session, we are pleased to have with us Dr. Honora Englander. Dr. Englander joins us today from Oregon Health and Science University, where she is Associate Professor of Medicine, Medical Director of Community and Clinical Integration, and Director of the Improving Addiction Care Team, Impact. And before we begin, I want to bring to your attention that today's webinar has been approved for 1 hour of CME. We will be sending out an email to all participants following today's call with more information on how to claim your CME. And with that, I will turn today's call over to Dr. Englander.
Great. Thank you so much for the introduction and for the opportunity to be here, and thanks for everyone on the webinar for joining. Before I begin, I want to acknowledge our pretty broad interprofessional team, our clinical team, as well as our research team, and our numerous partners. I lead this work at OHSU with a number of community partners across the state. I also do want to note that the chat box is open if there are questions. I'm really interested in knowing participants' questions. I'm going to move through the talk. We'll have time for questions at the end, and there'll be opportunity to reach out after as well. But again, I'm interested in knowing what you're working on. So to begin, the objectives for today is first to understand needs of hospitalized adults with substance use disorder, or SUD, to recognize hospitalization as a reachable moment to initiate addiction care, to learn about one academic medical center's experience developing and implementing a hospital-based addiction medicine team, and finally to understand how a team-based approach can improve care for adults with substance use disorder, and really to apply some of our lessons learned, hopefully, to your settings. This is a case example that I'm just briefly going to describe. It's a scenario of a case of a young woman who I cared for back in 2012, who really was one of many patient narratives that really, for me, was a major motivation to develop and implement this work. She was a young woman with a history of IV heroin and methamphetamine use who was admitted to the hospital with a MRSA endocarditis. And in August of 2012, she was admitted, then discharged to a skilled nursing facility. And at that time, she had reported that her last use was 2 months prior. She subsequently was readmitted the next month. She was initially admitted to a referring hospital. She was admitted and transferred to OHSU, at this time with an abscess around her aortic root. At OHSU, we're a quaternary medical center. She had cardiac surgery to replace her aortic valve. Social work was consulted, but really she had a lot of limited engagement. She had her boyfriend had recently died of a drug overdose. She was really grieving. And she was encouraged to seek treatment, but felt not to engage in or have a lot of interest in treatment. She was discharged with a lot of dilaudid. And then I met her on this subsequent admission where she was readmitted with chest wall pain. And at that time, again, despite my best efforts and our team's best efforts, it was really tough to fully engage her. And then subsequently, several months later, she was readmitted and she died in septic shock in our ICU. And her story really highlights, I think, a number of things. One certainly is just the devastating effects of this disease of addiction, but also the tremendous resources that hospitals are investing in the medical and surgical care of patients with substance use disorder. And I felt particularly frustrated because I felt like we really didn't have the systems in place to optimize the root cause of people's complex healthcare problems, which was really a team to address the addiction. So her story and many others were impetus for this work. So just a little bit of background, we're a nation facing a crisis. In 2015, overdoses exceeded the annual deaths at the peak of the HIV epidemic in 1995 and killed more Americans than in the entire Vietnam War, just in the year 2016. And addiction is a chronic disease of the brain, so an outdated view is that it's a moral failing or a bad choice. And really a modern evidence-based view is that there are both genetic and environmental factors that predispose to chronic drug use, and this leads to structural and functional disruption of the motivation, reward, and inhibitory control centers in the brain. And it's this change in the brain that turns drug use into an automatic or compulsive behavior, the disease of addiction. And just to further underscore this, this is a PET scan, and you can see the warm colors are high levels of activity, the low colors are cool levels, the cool colors are low levels of activity. And on the left we have a control brain, on the right we have a brain with cocaine addiction, and you can see in the orbitofrontal cortex, which is an area of the brain that's particularly responsible for inhibition and compulsion, there's low activity in a cocaine-addicted brain. And this is not, this is not dissimilar to a heart that has ischemia, where we see high levels of metabolic activity in a healthy heart and low levels in a diseased heart. Stepping back now towards more of an overview and the context of this disease in our hospitals, overdose deaths over the last, from 2000 to 2015, and unfortunately these numbers are skyrocketing even further, they're increasing. And I think sort of a very popular narrative, and one that's certainly important to pay attention to, is that it's prescription opioids that are sort of the root cause of this problem. And there's no doubt that overprescribing has contributed to this epidemic. But the nature and the epidemiology of the epidemic is changing, and really now it's heroin and synthetic opioids that are both driving overdose deaths, and there's some new emerging data that more and more new initiates of opioids are also starting with heroin and injection drug use. And I think this matters because it's just important for us to understand the nature of the epidemic as we tailor solutions, and I think a supply-focused solutions really will fail us. We really need to expand and think about treatment. I also wanted to show the nationwide clinical treatment gap. So this is a little bit of a busy slide, but on the top line here you can see the number of people with an opioid use disorder, and this is from, the terminology is somewhat outdated because it dates back to 2003 to 2012. The terminology has changed from abuse and dependence to use disorder. So this is looking at the number of people with a use disorder in that top solid line. And then the dotted line is the combined methadone, people who are in methadone in addition to buprenorphine treatment capacity. And what you can see is that in 2012, this gap represented close to 1 million individuals, even if all buprenorphine prescribers were providing at their full capacity, which we know is not the case. And again, just we have a massive treatment gap. And finally, from a hospital vantage point, there's been a marked rise in hospitalizations, a 64% cumulative increase in opioid-related hospitalizations, and this doesn't account for other substances across the U.S. between 2005 and 2014. So in summary, substance use disorders drive high rates of hospitalizations. There's also data to support that they drive high rates of readmission and long length of stay. And there were $15 billion in U.S. inpatient charges related to opioid use disorder in 2012. And despite this, many people are not engaged in addictions treatment. And the health system has been slow to respond. Just as I described with my first patient, hospitalization often addresses the acute medical illness, but not the underlying cause. And this leads to significant waste and poor patient outcomes. And there are effective treatments that exist, but they're underutilized. So to address this, we led a mixed methods needs assessment starting in 2014 and surveyed 185 hospitalized adults and with substance use disorder. And we learned a number of really key things. One thing we learned is that hospitalization is a reachable moment. So 57% of high-risk alcohol users and 68% of high-risk drug users reported wanting to cut back or quit. And this was on a survey. This wasn't even with motivational interviewing and other sort of motivational enhancement techniques. And patients also told us that they wanted a medication for addiction, and they wanted this medication to start in the hospital. We learned that there were significant gap times to community treatment. So in order to start somebody on methadone or Suboxone in the hospital, we need real-time access to treatment after discharge, in particular for methadone, because that you can't prescribe at discharge. And so this was a really important piece of what we learned. And then finally, patients told us that they valued treatment choice and that they wanted providers that understood substance use disorder. As one patient described, most of us that do it can't stand it, referring to her drug use. I hate the stuff. It's wretched. It's like damned if you do, damned if you don't. When I do it, I don't even feel good anymore. Like it takes so much just to be okay, to be normal. It's like when I use, I just feel normal. So they don't understand that. We also learned that patients with substance use disorder had longer than expected length of stay. So this is a figure showing of the 185 participants in our study. On the y-axis, we have expected length of stay. On the x-axis, their actual length of stay. And that solid black line is the line of identity. And what that means is that if actual and expected length of stay matched, what we would expect is that those dots would cluster, all the dots which represent an individual would cluster around that line. And instead, what you can see is that actual length of stay far exceeded the expected length of stay in most cases. And that in particular, in patients who had osteomyelitis or endocarditis or bloodstream infections, that these folks had an even more extended length of stay. And finally, to sort of further the business case for this, we looked at a mean observation period of 4.5 months. And among the 165 patients that had, we had to sort of do this a little bit sooner than the full 185 patients because of budgetary constraints, but among 165 patients, there were 137 readmissions over this time window. And the mean charge per readmission was $31,000, even higher for endocarditis and osteomyelitis. So again, very costly population. And so what we then did was we took needs and convened a group of community leaders, community stakeholders that were invested in this work, either from substance use treatment programs or a whole variety of settings, to really come together and look at the data and map needs to components of the intervention. And it was also important that we had information that could support a business case. But at this point, we didn't get into how the care model would be funded. We really started with the model design. And so because we learned that hospitalization is a reachable moment and that OHSU lacked expertise to assess, engage, or initiate treatment for substance use disorder, we developed an inpatient consult service. And our consult service includes physicians, social workers, peer recovery mentors with lived experience in recovery. We actually now have a nurse practitioner and we'll soon have a part-time PA as well. Because there were no usual pathways to outpatient addiction care and there are long community wait times, we developed rapid access pathways to community treatment, and we utilized treatment liaisons who worked part-time in the opioid treatment program and at one of our community health centers, and part-time with impact. And then finally, because patients needed long-term IV antibiotics at such long lengths of stay, and because residential addictions treatment is not equipped to manage patients with complex medical needs, and in particular IVs, we developed a model that I'll tell you briefly about and that we've actually since stopped doing that integrates IV antibiotics into residential care. And we launched in summer of 2015. So our experience to date, between July of 2015 and August of 2017, we served 602 individual patients, and these are some of the demographics. Mean age of 50 years, those a lot of folks younger, and then certainly some older folks. About half live in the Portland metro area, and about half Oregon is a large rural state. About half live outside of the Portland metro area, and that introduces certain challenges in terms of rural access to treatment. You can see high rates of homelessness, 46%. And then the sort of split in terms of people's primary substance of choice, about 46% with opioid use disorder, 33% with alcohol, and 11% with a methamphetamine use disorder as primary. A lot of overlap between opioid and meth use disorder when we look at the polysubstance data. And in terms of our levels of engagement, we measure engagement with a pretty low bar for purposes of reporting, which is that somebody meets us and wants to continue to work with us. About 88% of people did want to continue working with us in the hospital. And you can see that the range of physician and social work encounters are quite varied. Very intensive, so the most intensive was 33 physician encounters and 31 social work encounters. And when we look at kind of what we did, we were able to link 67% of people to community substance use treatment. We started medication for addiction on 64% of people, reduced controlled substances, identified unrecognized mental illness, and then also one of the things that we don't do, we only did 4% of the time, but is often quite impactful, is working with the criminal justice system, parole officers, and others to squash warrants and help people access treatment instead of having that kind of muck up the waters. And in terms of kind of how successful have we been with these treatment linkages, so we don't have data yet from sort of the Medicaid data set, which is something that we will be doing in the future, but we do have a data use agreement with one of our community partners. And so in that cohort of this of the 167 people that we referred, about half, 46%, actually enrolled in treatment, and there were a lot of reasons that they didn't enroll. Either they had a different treatment plan ultimately, or there were barriers. But of those then who enrolled, we have fairly high levels of engagement with, at 30 days, 71% of people were still engaged in treatment, and at 90 days, 44% of people engaged in treatment. And we'll be doing a more sort of rigorous and formal analysis across multiple treatment settings down the road. Briefly, the medically enhanced residential model, and this was the IV antibiotics integrated into residential treatment. We piloted this for 6 months, and during that 6-month window, there were 45 patients who needed long-term IV antibiotics, as defined by 2 weeks or more. But of those, only 7 actually discharged to this medically enhanced residential. And then of the 7 who went, only 3 completed their recommended antibiotic course. So we did a separate analysis and study to understand this further, and there were a number of reasons, but we had low recruitment. In part, some patients were too medically complex, even with the antibiotic infusions at residential, to be able to transition to residential. They either needed skilled nursing facilities or they needed multiple daily antibiotics, and we couldn't accommodate that. But I think the more important lesson learned is that ambivalence was a real driver for people not wanting residential treatment. And patients told us, they ultimately, when we studied this, that either they wanted to prioritize their medical care, there was fear of inadequate pain management, or patients had a lot of resistance around the idea of the residential blackout period, which is a 30-day window in which people can't use phone or internet, and they just weren't, while ready to engage in treatment and change, they were not ready for that level. So because of this, we ended MERT after 6 months, despite a relatively important but modest savings. So 101 hospital days equates to about $360,000 in savings. So it would have been financially sustainable, but we just didn't feel it was the right thing to continue. So with that, I'll just briefly summarize our savings through other mechanisms, and we were able to shorten length of stay and save 460 hospital days in our first year. And we have some compelling data around improved patient and provider experience, and also around reducing non-productive staff time. I'll just share a few quotes from our qualitative formative evaluation. As one hospital has said, impact elevated the consciousness of providers and nurses that substance use disorders are brain disorders and not bad behaviors. And as one ward nurse described, I think you feel more empowered when you've got the right medication, the knowledge, and you feel like you have the resources. You actually feel like you're making a difference. So now I'm going to shift gears and move away from sort of the description of our experience to date, and start to think about how can hospitals apply the impact experience and lessons learned in other settings. What are some of the sort of generalizable lessons and tools that that you might translate? So I broke it down into sort of 4 key tools. One is medications for addiction treatment. And then the next tool we'll talk about are pathways to treatment after hospitalization. I think the value of an interprofessional team, including peers. And then also I'll briefly talk about patient-centered safety plans. So I'm going to use a case to highlight some of these aspects. And this is a 26-year-old man with a history of depression, chronic back pain, and heroin use, who was admitted to the hospital with a femur fracture after a motor vehicle accident. And he underwent an ORIF of his femur fracture earlier in the day that I met him. And impact was consulted because he had severe pain and because of his heroin use. On further history, he told us that he started using prescription opioids at the age of 18 and transitioned to heroin 2 years ago. Initially, he'd used intermittently, but now he used a total of 1 gram of IV heroin a day. And really told us that he was using because of the fear of withdrawal and also that just compulsion to use. He'd never had an overdose, and he was having a lot of consequences of his disease. He quit his job a week ago, and one of the things he told us is that heroin gives him energy, and I think that term often, for me, is sort of resonates as to, or can be a clue to a use disorder. It also makes him depressed. It was interfering with his family and friends and work. And he described some co-occurring benzo use, rare methamphetamine use, and ongoing tobacco use. On exam, he was on a hydromorphone PCA when we met him. I went in with my social worker and peer when we met him, and he really appeared miserable. He was mildly tachycardic. He was mildly tachypnic. and tearful and really very uncomfortable. His pupils were slightly dilated, he was diaphoretic, and he had track marks in his antecubital fossa. So the first tool that I want to talk about are medications for addiction treatment, or MAT. Sometimes you'll hear this also referred to as medication-assisted treatment. I think medication for addiction treatment is kind of perhaps a more appropriate way to talk about MAT, because it doesn't always have to be, it can be the primary treatment. So in talking about reasons for MAT, one main reason can be to treat withdrawal. So as one hospital has described in our qualitative study, you see this pattern, especially in the IV drug-using population: left AMA, left AMA, left AMA. 9 times out of 10, nobody was dealing with the fact that they were going to go into withdrawal. And this was talking about care before the impact model was implemented. So how do we manage withdrawal in the hospital? Methadone is one possibility. I don't have time in the scope of this talk to kind of get into the details as to how to do that. But very briefly, low-dose methadone, we usually start with 10 to 20 milligrams of liquid methadone and titrate up to a max of 40 milligrams on day 1. Can be highly effective to manage the cravings and active withdrawal symptoms. People often still have cravings at a dose of 40 milligrams, but again, it makes a significant difference in terms of the acute withdrawal. And then buprenorphine or buprenorphine, which is also called Suboxone, is another medication that's highly effective to manage withdrawal. And both medications, I'll share very briefly some data, but both of these medications, when continued, have very significant improvements in terms of mortality as well. There are also adjunctive medications like clonidine, hydroxyzine, NSAIDs, and Tylenol that can be effective to help manage withdrawal, in particular when done in combination with agonist therapy such as methadone or buprenorphine. And again, here's the study I was referring to about medications, that medications save lives. So we know that buprenorphine, from this systematic review and meta-analysis, that buprenorphine cuts mortality, including overdose as well as all-cause mortality, by about half, and methadone cuts mortality by about 2/3. So again, I think in my experience, there are many hospitals around the country that are not providing medication for addiction. I think this is a hugely important area in which we as hospital providers can and need to make a difference. If there was a heart medicine out there that had this kind of effect, you can be assured that it would be widely implemented. So why are we not doing this? What are some of the common barriers? So here I'm going to talk about some of the barriers and then how we might address them. So one that I've experienced a lot is this misconception or idea that methadone in the hospital is illegal. So this is false. What's true is that you can't prescribe methadone at discharge, and that methadone for the treatment of an opioid use disorder in an ambulatory setting needs to be dispensed at an opioid treatment program, like a methadone clinic. But the idea that you can't prescribe it in the hospital is not true. So what we did to address this is we updated policies. Some folks may have to write hospital policies around that. And then we did a lot of work to educate providers and pharmacists and nurses. And the impact model is not yet expanded to our emergency department. And just the other day I called down because I had a patient who I know well who was readmitted and was in active withdrawal, and I had to sort of re-educate the ED provider that yes, it's legal and safe to provide low-dose methadone for these patients. I think another barrier is that a lot of providers don't know how to prescribe these medications, and so, and in particular buprenorphine. And so some potential solutions to that are that providers get buprenorphine waivered, and now physicians as well as nurse practitioners and PAs can get waivered, and I would encourage everybody to do this. You can do it online, you can do it in person. There are some courses that are a hybrid, but it's a really powerful way to learn about how to use these medications. And then I think another key piece of provider education is identifying interprofessional staff champions. So this is a team sport, and having not only physicians but nurses and pharmacists and social workers that can understand the treatment models is really important. And then finally, a major gap is that there are no pathways to treatment after hospitalization. And I'll talk more about how folks may go ahead and build them. So continuing on with our patient, let's see. Actually, I just want to ask, is there a problem with my slides for folks? Just to ask the other moderators, I noticed some typing.
Hi, Dr. Englander. We can see your slides, yes.
Okay, great. Sorry, I saw in the box there. Just wanted to make sure. Thanks. Okay.
Our
So
operator, Chelsea, will connect with those who might be having issues.
Okay, thank you. So continuing on with our patient who I started with, again, just to recap, he was in active withdrawal. Of note, he was on a dilaudid PCA, and I think it's important to note that IV dilaudid is not necessarily a good treatment for withdrawal. Because of its intermittent and sort of very high peak, high on, high off nature. So we started him on methadone, 20 milligrams of liquid methadone, and within hours, we came back to see him because he'd been so uncomfortable. Came back, he felt a huge difference. His pain was better controlled. His mood was much improved. And actually, within a day, we were able to transition him off of the IV dilaudid PCA and onto liquid hydromorphone or dilaudid. And then as we increased his methadone, so he became quite interested in methadone as a mode of treatment. So as we increased his methadone, we titrated down his hydromorphone. And this is something that we see a lot, which is this real transformation once people's withdrawal is treated and they get the stabilizing effects of agonist therapy. I often feel like you can sort of see people engaging their frontal lobes. So the next tool we can talk about is post-hospital treatment pathways, these linkages to care after discharge. And so just a few data from our qualitative work. As one hospital said, this isn't just like we're being nicer. This relationship with our community SUD treatment provider is ingenious. It's like an answer to our prayers. And as another hospitalist described, starting them on methadone or Suboxone and then making the next step in the outpatient world happen has been huge. That transition is so critical. It's probably the biggest impact. So I wanted to kind of define a few steps to developing these post-hospital treatment pathways, because a lot of people that I talk to feel like it's not that intuitive necessarily how to go about doing it. So I think the first thing is really to identify who are key stakeholders in your community, and this may be the opioid treatment programs. It may be in rural areas that there are no opioid treatment programs, but perhaps there are office-based buprenorphine providers. And then I think other members that we convened and found very helpful to include were housing agencies, skilled nursing facilities, the payers, and others. The next step is to convene leaders really to understand gaps and opportunities across settings. And I don't think that every hospital needs to do a formal needs assessment, but perhaps pull a series of cases and just get people's experience to hear what's working, what's not working from these diverse perspectives. And then finally to identify what are the pathways that might be supportive and how do we support them. And I think it's at that last step where you can start to think about both operationally and financially how might something look. For that reason, I'd encourage folks to include the payers at the table, perhaps sooner rather than later. The payers certainly, I often find that I have to remind folks that they're already, as I showed in those earlier slides, already investing a tremendous amount of resources. So the risks of spending a little bit up front in a different way are perhaps lower if you put it in the context of just the massive expenses that are already being spent. The next tool I want to talk about is the interprofessional team, including peers who have lived experience in recovery. So I'll talk about our impact roles briefly. So, and kind of not only who the roles are, but what we do. So impact has physician FTE. We actually currently have 1.5 physician FTE divided amongst 5 of us. And then we also have a full-time mid-level or nurse practitioner, and we'll be bringing a PA on board. And that role is really to diagnose substance use disorder. And we use the DSM to diagnose substance use disorder, certainly to identify and treat withdrawal and initiate medication for addiction treatment, as I've talked about. And then we also assess patients' other medications and look at risks and potential benefits there. We're often prescribing medications for sleep, for PTSD. We assess mental health and pain control. And while we're pretty clear that we're not an opioid stewardship team in the hospital, we do help with safe opioid prescribing, and sometimes that means lowering opioid doses, sometimes that means increasing opioid doses. And then we also, anybody with an opioid use disorder, we encourage naloxone prescribing at the time of discharge. Our social workers really focus on assessments in terms of doing a really comprehensive social work substance use assessment. They use ASAM, or the American Society of Addiction Medicine. They also work with our nursing staff around a safety plan and relapse prevention, and I'll briefly talk about that in a few minutes. They do behavioral treatment in the hospital, including psychoeducation, motivational interviewing, and finally they do spend a lot of time around care coordination, both within the healthcare system in the hospital and outside of the hospital, as well as the Department of Criminal Justice and other organizations. And then finally, our peers really focus on patient engagement and empowerment. They also support patients as they navigate a complex health system and complex social service systems. They provide social support, both sort of emotional as well as instrumental social support, helping meet people at appointments and all kinds of support. And they're a bridge both across the hospital and community settings. And this is a nice quote from one of our social workers in the qualitative evaluation, that having an addiction team, including doctors, quote, in a white coat, completely reframes addiction as a medical condition that actually has a treatment. So we've again found that having a dedicated team addressing addiction has reduced some of what I would call the structural stigma of this disease, and kind of quote, and others have told us, quote, legitimized the disease of addiction. And the value of peers in our experience has been just huge. This is a quote from our patient needs assessment that I really like. The patient said, "When you tell me what to do, I'm a mule. I dig my hooves in and I'm like, I make my own decisions. But if you have somebody to talk to that could understand where I'm coming from, yeah, I could see that helping people." And I think there's a lot to unpack and understand about kind of the value of lived experience, but it's very powerful. There are some challenges to implementing peers, so I'll talk about just briefly in terms of the reasons why I think peers have such a huge value. In particular, if patients have low motivation or are struggling with behavioral issues in the hospital, it really helps them engage. They also play a really key role in informing our program development and quality improvement efforts. I bring the peers with me to senior leadership meetings because their voice is so rich and so different in terms of just understanding the patient experience and understanding the disease of addiction and all the complications. Hiring can be complicated. If you do decide to have peers, you should sort of be prepared that many have a criminal record. And what we did, and I think was really helpful, was we met with human resources, legal, and risk management. So I sort of set up a meeting with all the folks in that arena before hiring to tell them about the care model, to tell them about what we were trying to do, and to kind of warn them that it might get sticky and that I might need their help. And I think including them as part of the team to kind of find solutions was smart in advance, because we did run into some challenges. And then finally, I think supervision is really important. So we contract with a community peer agency. Our peers are not OHSU employed. They're very much integral and sort of included as part of our team, but they have an outside agency that they get mentorship and support from. They also have supervision within our OHSU social work team, but the kind of dual supervision I think is really helpful. And I'm really fortunate I have a strong relationship with both of our peers, and am able to both learn from them, and then also at times I think because we have a strong relationship when they need feedback or guidance, that foundation is really important. So I would recommend a strong relationship with the physician champion. Just a brief note about that. My colleague, Onisha, who's a peer, she refuses to call me Honora by my first name. And when I asked her why, she said, "I finally have a friend that's a doctor. I'm never going to call you your first name." So she always calls me Dr. Englander, which I think is really funny. So getting back to our patient, he discharged on hospital day 5. We wrote out a very clear opioid taper plan, and he had plans to follow up in primary care and at the methadone. So in primary care in about a week, and the methadone clinic the next day. So because of our pathways to care, we were able to dose him on the day of discharge at OHSU, and then the next day at a local methadone clinic. And I also work at a federally qualified health center 2 half days a week, and I happen to have the privilege of seeing him 2 weeks later. And he walked into clinic using a walker and was just sort of glowing. He reported that he was fully engaged in substance use treatment. He was on methadone and had been titrating that dose up. He was off of the hydromorphone. And in fact, that he was working with our peer who recently accompanied him to enroll in college classes. And as it happens, I happened to see him this past Monday in clinic, and he's doing beautifully. He's got, I believe he has over 90 days of sobriety, and he's doing really well in his courses, and he's reconnecting with family. And so, again, really a very lovely success story. So I just want to take a few moments to talk about stigma. I don't think I have that many more slides, and we'll have plenty of time for questions. But in terms of stigma, so we use the DSM, which you can diagnose a mild, moderate, or severe substance use disorder. And this is a diagnosis. But the term addict, and there are many others, really are harmful labels. And I think we, as providers who are working to improve care for people with substance use disorders, it's so important that we don't use these harmful labels, and that we recognize that they are barriers to patients seeking treatment and patients doing well in our care systems. This is a nice paper by Michael Botticelli, who was the former head of the Office of National Drug Control Policy, that really kind of gets into this a little bit further about the language of addiction. And in Massachusetts, there's been a statewide efforts to reduce stigma. And I like this quote: "The stigma of drug misuse keeps people from seeking treatment. Words like junkie, addict, and druggie can hurt, damaging self-image and standing in the way of recovery." And I guess sort of a little bit along those lines, the idea of opening up those lines of communication, reducing stigma, really, and providing treatment, really can change the nature of the dialogue that we have with providers and patients. And this is a quote from our needs assessment. "I don't know if it gives them a voice or allows us to hear them better, but something is happening with communication." So the last tool that I'll talk about briefly is around patient-centered safety plans. And so at OHSU, our hospital nurses have been leading a process around patient-centered safety plans. And I just want to sort of briefly describe what that means. So we as an impact team, but I don't think this has to be the impact team, it could be any provider. The initial conversation that we have with somebody who we know has an active substance use disorder is, and we frame this as a routine conversation, and it is a routine conversation, and with the goals being to assure patient safety and staff safety. We talk to people about their drug use and acknowledge that the compulsion to use and cravings and active use is a part of the disease. And we want patients to talk to us if they're concerned that they might have active use in the hospital. We also ask them to discourage visitors who might bring in drugs or paraphernalia. And we explain that sometimes patients may have a random room search or a random urinalysis as part of hospital care. And in fact, for patients that we do start on methadone and Suboxone, we tell them that UAs, regular UAs, are going to be a part of their treatment. And then if there's concern for active use, this sort of is a trigger for what we call kind of a level 2 safety plan. I didn't think I would have time to kind of get into the details of this, but essentially what it includes is it acknowledges that these above things might happen more frequently if there's concern for active use. And in some scenarios, it asks patients to have limited time off the floor. And so I think having a strategy that's this is something that's ongoing work for us, and I think we've done some good work, and we've got a lot of work ahead to do this well and really implement this well, but it does feel important both to kind of call out that these behaviors of addiction are part of the disease, and then that we really want to support people to complete their treatment in the hospital safely, and that it's not to be punitive and it's not to catch anyone, but important to acknowledge these risks. And I personally have had experiences where if I'm going up on somebody's methadone dose, I tell them, as part of your routine care, you have to check your urinalysis. Have you used within the last week? And I find out that they in fact have. And so then how we approach that and how do we do that in a trauma-informed way is really important. And I think the nurses and the rest of the staff feel much more supported when we have systems in place to do it and have the addiction medicine expertise to support kind of a deeper understanding of use patterns. And this really leads to a sort of bigger question around harm reduction and what does it mean to practice harm reduction in the hospital. Harm reduction is defined as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And I wanted to bring this up in the context of this talk because I think more and more there are a number of people who hospitalization is a reachable moment. They want to initiate care or treatment for their underlying substance use disorder, but there are also people who are not ready and that's not what they want. And I think it's our responsibility as healthcare providers to do our best to care for them. We're in the process of figuring out what that looks like in the hospital. Just yesterday I received a letter. It was sent to me by another provider who was sort of the recipient of the letter. But basically the patient said something to the effect of, it's your job as hospital providers to care for my medical needs and not fall into sort of fairy tale delusions. Those were her words. And the idea being that she was not ready to quit, and she unfortunately left against medical advice, I think because she just couldn't navigate a space in the hospital where she could sort of get her needs met. So I think this is another, just a future work for us, certainly. So with that, I'm going to summarize a few things and then open it up for questions. What I would call kind of the core elements of an impact model, if that's what hospitals are interested in doing, though I think it's also possible to do pieces of this. But again, for an impact model, I think would be leadership buy-in and support providers that understand addiction, systems and policies that support medication-assisted treatment, and strong community partnerships, including linkages to post-hospital care. I think that some key process steps for us in terms of building the impact model were to identify local needs and drivers for change, and really to try to get a sense of what's the scope of the problem, both from the perspective of the hospital and the community and the region, to identify key stakeholders and potential champions, and then convene these partners across disciplines and settings and talk about really what are the needs. Subsequently, to map needs to components of the intervention. I think the next step is to identify metrics, timeline, and communication strategy. That was work that we very much needed to kind of do throughout this process of development and implementation. And then finally, continuous quality improvement with continued engagement and involvement across stakeholders. I want to point folks towards one toolkit that the American Hospital Association has created that I think can be really valuable for folks. It's an opioid toolkit that has 8 different categories of topics, which you can see here, including education on prescribing practices, non-opioid pain management, how to address stigma, treatment options for opioid use disorder, patient and family caregiver education, transitions of care, safeguarding against diversion, and collaborating with communities. So this can be a really useful resource for folks interested in improving your local care system. And with that, I'm going to end with a photo from one of our impact patient whiteboards. I walked into his room one day and saw this: feeling good, on the road to recovery from addiction, on the road to surgery to save my life. He was undergoing aortic valve surgery. Then I start my new life as an awesome dad in person. Thanks to all that helped me through this hard process. And this was a guy where, man, it was a battle. He really, really resisted. And through continued work and engagement with our peer and social worker, he acknowledged that he had a disease of addiction, and we ended up getting him on Suboxone, and he did beautifully. So I like this picture. And with that, I will open it up to questions. I put my email on here as well as my Twitter feed, partly to remind myself that Twitter is a great space to learn about addiction medicine. I am not social media savvy, but I do really like Twitter because of the opportunity to learn more about addiction. And with that, I can open up to questions.
Yeah, and as questions come in, Honora, we did have several questions throughout the presentation. So we just want to start with one of those. We had one come through from Megan Carter, and she asks, did your team encounter or find a need to address patient use of illicit substances while they were admitted to the hospital? If so, how did this impact your interventions?
Yeah, so absolutely, and this is something that we continue to, this may have been sort of an earlier question because I talk a little bit about it later in the talk, but you know, one of the tools that, so it's absolutely something, excuse me, that we encounter it we encountered it at the beginning, we encountered it now. I think I used to be a little bit more naive to the idea of how many, I think when I was practicing as a hospitalist and not an addiction medicine doctor, I don't think I realized how many people were actively using, and now if I see somebody on relatively low doses of oxycodone in the hospital, and they're not in active withdrawal, it's pretty evident to me that they're using, and so I think I under-recognized it previously. And the way that we address it is, one, to understand why people are using. If they're using because of fear of withdrawal, then certainly we can support them and we treat their withdrawal. Other times they're using because they are not ready to stop using, and so that can be really difficult. And that's work that we have ongoing in terms of kind of how do we support a kind of a patient-centered environment that people can complete their medical treatment, but also I think staff have a lot of concerns, often very appropriate concerns about staff safety and other patient safety. So we've seen a huge decrease in the really disruptive patient behaviors that we used to see a lot. We have some qualitative quotes about how everybody used to, quote, get all spun up, end quote, around these challenging patients and challenging behaviors. And now we see really kind of a massive shift in terms of provider feeling supported and providers understanding the chronic disease of addiction, and also just provider satisfaction. So anyway, I hope I answered that question.
Awesome. And then we also had a question from Casey Ferguson about infectious disease doctors as stakeholders and if they were involved in the program at all.
Great. Hi, Casey. That's a great question. So our infectious disease team, we used to have an OPAT team, which is an outpatient parenteral antibiotic team. We still do, but some of the personnel have changed. So our ID team has been really key partners in this work. When we were doing that model where we were bringing IV antibiotics into residential, they actually did sort of weekly telehealth rounds in residential with folks, and they were playing a very sort of explicit role. But working with the ID teams is so important as we think about transitions of care and discharge planning for people who may need to leave the hospital with PICC lines, or who may not be safe to leave the hospital with PICC lines and need to complete their course in the hospital or at a skilled nursing facility. But we work a lot with the ID folks, and I know at certain institutions, I know that at the BI in Boston, it's their ID docs actually that have gotten buprenorphine waivered and are in the outpatient setting providing access to buprenorphine. So I think ID physicians and providers can play a huge role in improving these care systems.
Awesome, thank you. And I see Dana Clifton asks, are the providers on the IMPACT team the only ones who prescribe MAT for inpatient withdrawal, or do you train all hospitalists to prescribe as well?
Yeah, so that's a great question. So we are not the only ones who prescribe, and our goal is to really upskill other providers across the organization to do this. I would say we've had varied success in that, partly because we need to dedicate more time and energy to provider education, and partly because I think there's a variety of reasons. But we've written a methadone protocol that we have that people can pull up easily in Epic, and so that I often will kind of get a call on my way out the door and just talk the resident through the methadone induction if that's the right choice. With Suboxone, the inductions are a little bit more complicated, though they're not that complicated. And so we're working to get all of our family medicine residents, and actually all of our family medicine residents already do get bup waivered. We're this year for the first time having all of our internal medicine residents get trained. It's kind of an interesting time in which trainees may be more equipped to manage this disease than people who've been in practice for some time. So again, we've got a lot of work to do around provider education, not only physicians, but also nurses, social workers, pharmacists, and others. But the idea is that we sort of raise the quality and sort of competency of everybody's care, not just provide the specialty service.
Awesome. And Robert Merchant, he asks, do you have a pain management team which is separate from the opioid addiction team? If so, what is the overlap?
That's a great question. So we do. We have an anesthesia pain service at OHSU, and we have started meeting with them every other week to review cases and figure out how do we best work together and just learn from one another. And so the pain service is one of we get referrals generally from the primary teams, but the pain service also will often be the ones to say, hey, I think you guys should get the addiction team involved. And it's nice to be able to work with them because certainly acute pain can be, sometimes it's tapering the pain medication in the outpatient setting is when the addiction really kind of is revealed. In the hospital, managing patients' acute pain in the setting of substance use disorder can be so challenging. So we work a lot with them, and I think that's another important relationship, just like ID.
Okay, I see we have another one here too from Diana Kaffa. She says, do you have any issues with 42 CFR regarding charting, or do you get around it by not providing treatment, but instead providing advice to general medical teams about treatment provisions?
So that's a really good question. So for folks that may not know, 42 CFR, and again, don't quote me on this, but I'll tell you my rough understanding. 42 CFR is a federal regulation that basically is around the protections of privacy for addictions treatment. And because we are not a licensed addiction treatment setting, what we do in all of our notes is we have a disclaimer that basically it has some statement, and I did meet with our legal folks about this, that it's a disclaimer that says that this is sort of somehow privy to 42 CFR, so that it allows us to then write our notes. We don't have like a separate break the glass or anything like that for our notes. When I was starting Impact, there are a couple of hospitals that I know of across the country that are doing some similar work at Boston Medical Center and at Mass General Hospital in Boston. So I spoke to some folks nationally with the addiction medicine societies to kind of get their input. And to the best of my knowledge, and our legal folks have agreed, what we're doing is not illegal, but it's also not super well defined. I did read something on Twitter a few days ago that suggested actually that there may be some regulatory changes to loosen up those requirements also around 42 CFR.
Awesome. And I see we have a question here from Megan Carter. She asked, does your security team search patients' belongings at any point?
Yeah, so that is a really good question, and kind of I think it's an area where we can improve. I know that if somebody's found to have like rigs or paraphernalia on them, they do get a room search. There's been discussion about who does that, and this is discussion that I've sort of said this is hospital policy, not an impact issue, and quite candidly, I just don't have the bandwidth to kind of really get into it. But sort of whether or not it's the nurses that are supposed to search somebody's room and the nurses appropriately feel like that's pretty inappropriate and uncomfortable, versus whether or not it's security. At OHSU, our security is police, and they're Portland police, so that really complicates things. So patients do get room searches. They do get their belongings searched. When done well, it's done in the context of safety and not in a punitive way. But I think it's a little bit of a gray zone, and one that I think can get tricky. I think understandably people feel violated if their stuff is getting searched. So it's tough. We've done some work with our public safety folks around kind of understanding addiction as a brain disease and how do we go about that.
Great, thank you. We have another question, Charlene Brown. She asked, has your addiction team been trained on motivational interviewing methods for communicating and identifying patients amenable to treatment?
Yeah, so absolutely. Our full team has experience with motivational interviewing, our social workers in particular, our peers also, and MI is a key piece of one of the tools that we use. Mm-hmm.
Jay Endon has another question. Do you have a survey on culture, asking people about culture? Is SBIRT applied across your patient context to identify high-risk behaviors suitable for MAT in the ED or inpatient setting?
So if I'm hearing this right, there's two questions. In terms of the SBIRT, or a question which stands for Screening, Brief Intervention, and Referral to Treatment. So SBIRT is implemented in our EDs. It's going to be expanded and implemented across hospital units. SBIRT is really to identify, it's sort of a screening tool to identify people who may be high risk for a use disorder. And so that's work that's kind of happening a little bit in parallel to our work. We certainly are, our social workers are the ones who then are the sort of, if the SBIRT screen's positive, it goes to the hospital social workers. And then if they think that somebody's sort of impact appropriate, and we've done a fair amount of work with them, educating them on who are the people that we are sort of a biggest resource for, then we'll certainly get involved. And our impact social workers work closely with the unit social workers. I think for systems that are doing SBIRT already, it can be a really useful referral pathway. The other question was about culture, and this is something that I think is really important, and we do our best. I think our peers probably help us the most in terms of thinking about culture, addressing culture. One of our peers is an African-American woman who we had one experience that was really sort of important, where a patient's boyfriend yelled a racial slur at her, and I was in the room. It was very intense and upsetting, and he was very quickly escorted away. But it got us thinking about kind of not only for patients about culture, but also for our staff. And so we now routinely ask patients if they work well with people from all backgrounds, or if there are any backgrounds of people that they struggle to work with, partly to protect our team. I don't want to sort of expose, it's just to sort of make sure we're doing our best. Both OHSU has a very progressive policy about patients not being able to choose their provider based on preferences of race or ethnicity, and we sort of subscribe to that, but we also want to know what we might encounter.
Okay, and we will take one last question here. I see Hulata Brooks, she asks, do you have examples of policies that speak to the searches and conversation ward nurses are to have with the patients?
Yeah, the nurses have developed this pretty detailed script. It's being revised. Some of the language I think is a little tricky. It sort of starts with the number one thing is to stay sober while you're in the hospital. And I think, what does that mean? You know, is marijuana use in somebody with a methamphetamine and opioid use disorder staying sober or not, especially if they're here for long stretches of time? So we do have a kind of a patient safety plan. It's not a policy, but it's a guide, and it's being revised. And I can check with our nurses, but I'd suspect I'd be able to share it.
Awesome. Thank you so much, Honora, and thank you, everyone, for joining today's call. As a reminder, we will have a recording of this session available on our website, as well as the slides for download. This, again, is eligible for 1 hour of CME, so we will be sending out an email following this call